I've had the great pleasure, I've been in this game for a long time now, and early on in my learning, some guy came into a lecture as a guest lecturer and started talking about how the whole body fit together and how it all fit with the occlusion. And this was in the early 90s. He showed us an instrumentation that was able to measure cranial faults and how cants and pitches and rolls and yaws were in the maxilla, and how we needed to treat this to be able to get that joint in the proper position. It's been incredible to learn this and to be in here this early and to understand from some of the early masters and what they've gleaned throughout the years and what I've been able to take from them. With that, some of the lessons that Dr. Carlson has had is working in large institutes and realizing that they're not teaching the whole body.
And maybe someday dentistry will change, and they'll catch up to us. Now, teeth are only part of the whole. So it's all about the bones, it's about the muscles, it's about the joint and the dentition. And so I call these the 4 pillars. Someday it'll be 5. Once I know enough. I don't know enough today to come up and talk to you about neurotransmitters. I'm not here, I don't know enough about the brainstem. I don't know enough about plasma. I don't know how the cortex reorganizes itself, but I know it does. And I know that this thing is very important to what you're doing. And when Dr. Stack is showing these cases, it's not just about the temporomandibular joint. It's about neurophysiology and what he's doing to change this, to change this, to change what's going on with the muscles. So, and they're all interrelated. Now, if we can accept this model, if we can accept they're all related, and we then can take that back to our practice and start to integrate that into our practice, because if we accept this, which one don't you want to look at? If you're going to treat the occlusion, which one don't you want to look at? Years and years ago, we were at an orthodontic conference out in Seattle, and we had a bunch of us were going to take a course from the IAO, and Dwayne Keller came in and he started talking about the TMJ. Some of you might know Dwayne Keller. He's really another one of the true pioneers. And he started talking about the TMJ, and his dentist looked at me, I didn't come here to learn about TMJ. I came here to learn about orthodontics. I said, you think orthodontics has got anything to do with the jaw joint? Some of you in this room know. It's all interrelated. A stable occlusion relies on all 4. Now, I'm not talking about stable dentition. I'm talking about stable occlusion, stable bones, stable jaw joint, stable muscles, stable dentition. If you remember Dr. Almos's course lecture yesterday, he found that there was some instability after the teeth had already been restored. I think afterwards, something was wrong. Something's not stable. What? We got to look at the whole patient before you ever make the teeth together. So, ideal occlusion has stability during function. Now, to create this dentition, we are the dentition doctors. Your college in Ontario and colleges all across Canada, all over the United States of America, we have been given a monopoly. Nobody else can do this. Just us people. And to have a stable dentition, we must have stable joints. We must have a stable neuromuscular system, and the bones have got to be the best we can make them. So, dentition design, and I'm going to talk about dentition design. And I'll share with you, hopefully I've got enough time to do that, about dentition design. Ideal dentition design for your patients. And ideal dentition design is dictated by function.